Today, we will be chatting with Dr. Nolan Williams for a discussion on neural networks and synaptic connections. Dr. Nolan Williams is an assistant professor within the Department of Psychiatry and Behavioral Sciences at Stanford University, and he is the director of the Brain Stimulation Lab. Dr. Williams has a broad background in neuropsychiatry. Results from his studies have gained widespread attention in journals such as Science and the New England Journal of Medicine. Dr. Williams received the National Institute of Mental Health Biobehavioral Research Award for Innovative New Scientists in 2020. And with that, we welcome you.
Hey, thanks, man. Thanks for having me, and appreciate being able to be on this podcast. And yeah, awesome. Well, let's get going.
Let's get going. So first, I'd like to invite you to tell me and those tuning in a little bit about what your current lab is investigating and your latest research endeavors.
Yeah, definitely. So the lab is, is an experimental therapeutics lab. We've been, going at this for almost a decade now around this idea of developing new treatments, particularly in areas where treatments don't exist. So looking for places where the treatments that are available are limited or not really designed for that problem, or people have tried to develop treatments for that problem and haven't been previously successful. And so, yeah, we've got a number of things that we've been working on. One of them's kind of pretty widely out there, in the literature and in the lay press, and a couple more that are coming that are, kind of novel therapeutic approaches for neuropsychiatric illness.
Now, when you say novel therapeutic approaches, I am aware that you are investigating an interesting psychedelic known as Ibogaine. And this may not get as much media coverage as the classic psychedelics like psilocybin and DMT, or even LSD or MDMA. So can you give us an overview about what Ibogaine is?
Definitely. Yeah, so Ibogaine is some kind of use the term atypical psychedelic, some would use the term oniridan, which is they like to use, which means kind of induces almost a dreamlike state. It's a drug that interacts with some of the same receptors as the classic psychedelics, but has in this case, a much broader repertoire of interactions, with serotonin receptors, but also upregulation of glial-derived neurotrophic factor, for instance. And so it has this pretty unique psychological effect where you're really seeing folks experience what they call life review, or a kind of a marching through the chronological, emotionally relevant memories in their life, and then they seem to reconsolidate those and have new appreciations for those and new kind of understanding of those chronological events.
And if we were to do a Google search for Ibogaine, we can see that Kentucky just became a state that has received a lot of funding to focus on Ibogaine for looking at addressing addiction. Now, I know your focus might be a little bit different, but can you share maybe the mechanism of action and how this psychedelic is working?
Yeah, I mean, we don't know. We know maybe for the of a mechanism administration for a direct brain injection within the ventral tegmental area of the mouse of GDNF, and then been able to replicate the anti-addiction effects, right? But the mechanism beyond that is TBD, right? It's people haven't done the level of experimentation that it's going to take to really understand holistically what a drug like this that has a lot of different receptor interactions is doing.
So the literature is showing that this psychedelic, which has a very long half-life when we compare it to the classic psychedelics, has utility in addressing addiction. How does your focus and your lab perhaps change that approach? I know that addiction is not your area of specialty. Are you able to speak a little bit about what your work has shown?
Yeah, so I mean, we got connected with vets, with Amber and Marcus Capone, a number of years ago, to examine this substance as a treatment for traumatic brain injury sequelae, and the potential of even a TBI related effect. And so we were examining this in the context of veterans going down to Mexico to receive Ibogaine, mostly from word of mouth from their fellow veterans, as it being a particularly robust anti-TBI, kind of antidepressant, anti-PTSD sort of substance. And so, now I think there's been about 1,000 veterans that have gone down to Mexico and received this at their own volition, through the VETS program. But, at the time it was maybe 100, maybe less than that when we first started talking to folks and really trying to get, a handle on what was going on and why folks were making the journey down there to take a drug that's a Schedule I substance in the United States. And so we kind of use this as a way of kind of examining the effect of the Ibogaine, but also trying to characterize the individuals going down there prior to treatment.
Something you said there that's really striking is that you're looking at not only PTSD, but also TBI, or traumatic brain injury. And this is what I think could be a new frontier in the field, as we have mounting evidence that psychedelics can address mental health entities like addiction and PTSD. Addressing organic neurological tissue and injury is quite novel. So what do we think is going on to address brain age or address the actual injury to the brain tissue itself?
Yeah, it's an open question. I mean, we not to expose the upcoming results too much because we're still in peer review, but we essentially did a pretty deep dive on the neurobiology of Ibogaine. So we did neuroimaging work. We did a bunch of different neuroimaging modalities. We looked at EEG. We looked at functional imaging, as well as blood biomarkers, and we're really trying to understand how such a profound neurotrophic factor could affect the brain, affect the CNS, and understand what sorts of functional and structural changes we would see. So that's been an ongoing examination, and we have a lot of preliminary results there that look very promising that are going to go through peer review over the next 4 to 6 months.
It's very exciting, I must say. And before we transition into the next topic of neuromodulation, I think it would be wise to have you articulate not only the benefits, but are there any potential risks that Ibogaine carries?
Yeah, so one of the things that we were particular about is that.
And I think Dr. Nolan Williams's internet connection dropped out there. It sounds like he was speaking to the potential cardiac risk or cardiac toxicity of Ibogaine, as it can prolong the QT, which is part of the electrical rhythm. And most of that risk can be mitigated with magnesium. So we were just talking about the potential risks being maybe cardiac, in that it can prolong the QT, and maybe that risk can be mitigated with magnesium. Is that right?
Yep. So co-administration of drugs, in this case, magnesium is one of them, but drugs that have the potential to block QT prolongation and are used as a therapeutic treatment for the end kind of arrhythmia of risk that people worry about with Ibogaine, which is torsades. And the good thing is that our group of individuals that we studied, none of them had a symptomatic arrhythmia requiring any sort of cardiac intervention, and 30 people finish up on that trial.
Fantastic. And where do you see the future utility and use case for this particular therapeutic? And do you have any resources available for those that are interested in pursuing this pathway to seek healing utilizing Ibogaine?
Yeah, it's a great question. I mean, I think a big piece of it is this question around, is there a kind of a neuro rehab potential for these, these powerful neuroplastogens, right? So can we, go in and produce more, kind of immature brain states, which, as are more prone to kind of reassign function in the case of psychedelic drugs and Ibogaine. And so thinking about not just psychedelics as a psychotherapeutic tool, which I think everybody's kind of on the same page that's, one of the big possibilities for this, but also thinking about it as a neurological rehab drug, which I don't think as many people are really thinking in those terms, right? You are, a few other folks are, but, the vast majority of people are kind of thinking about psychedelics from this vantage point of it being primarily, a psychiatric drug, if you will.
Excellent. Thank you for that. We are going to now switch gears a bit and talk about your work looking at the application of neuromodulation techniques. Something that you've written about is examining the use of spaced learning theory. Can you tell us more about that?
Yeah, definitely. So, the idea of neuromodulation, and particularly of the more recent transcranial magnetic stimulation techniques, is an approach of playing certain informational rhythms into the brain, right? So playing rhythms into the brain that basically provide information about turning a system on or turning a system off. So if I stimulate with theta burst stimulation, I can actually turn a brain region on or turn a brain region off, or there are inert versions of that where it's essentially neutral. It doesn't do much of anything. And the way that we validate and evaluate that is really in the frame of the motor system, right? So the motor system is particularly useful as a readout tool for determining cortical excitability. That's been around since the mid 80s to 90s. Neurologists like Mark Hallett at NINDS were using this technique, and really it's a kind of a motor physiology kind of translational approach. And so if you can turn on and turn off the brain, and you can validate that in the motor system, then you can actually take that information, that kind of validation, if you will, and use that to apply it into other systems. In this case, into prefrontal systems that may be involved in emotion regulation. And so that's kind of the base framework that we really operate on as we're thinking about, using focal neuromodulation to stimulate brain regions. And so, the kind of basic idea for depression in the case of the circuit is that the left dorsolateral is underactive or under, kind of the tone of it is low. And what the dorsolateral does in part is it has a kind of a clamp down function onto the cingulate cortex, right? And parts of the dorsolateral and parts of the cingulate are involved in like pure cognitive control, like the sorts of things you'd see with a Stroop task, like the neuropsychological test. And then parts of the dorsolateral appear to be involved in mood regulation, specifically in clamping down a certain part of the anterior cingulate cortex called the subgenual anterior cingulate cortex that's involved in sadness and in the emotion of sadness. And so the dorsolateral, because it's such a broad brain region, has a lot of different kind of subunits that are involved. And so kind of, this as a neurologist, that part of what you're trying to do is you're trying to localize in this case, it's not a real lesion per se, although work has been done, I can talk about in a second, in that front as well, but more of a kind of an electrophysiologic blockage that functions like a lesion, or a reversal of information that works like a lesion, right? And we know that that kind of stuff happens too, right? That if you have a lesion in a certain place, it can mimic a stimulation effect, or a stimulation effect can mimic a lesion effect. We've known that since the era of deep brain stimulation for Parkinson's, emulating surgical approaches to essentially create lesions in the subthalamic nucleus and the globus pallidus, and have treatment effect for Parkinson's. And so what we know is, and this is from Mike Fox, a neurologist at Harvard, that if you take all the strokes that cause depression and you put them on the human connectome map, and you ask the question, what are these all functionally connected to? The answer that you get is that they're all functionally connected to the dorsolateral prefrontal cortex, this area that is the stimulation area for TMS generally. And so that's instructive, right? That kind of gives you this kind of lesion localization within the circuit of what within the circuit is problematic. And then you can ask, and so that's kind of like, if the brain is 50 states, that's asking the question of which state out of, in this case, like as an analogy, the United States, not cognitive states, but in this idea that there are a lot of different Brodmann regions, which state is this illness localized to? But then the second question is, you're not trying to find the state, you're trying to find the city and the parking lot, essentially, right? And so then you have to use connectivity metrics to get even more specific, right? And what you're doing there is you're trying to ask the question of, where within this big state or city do I park my car? And in this case, where do I place the stimulation approach? And then you have to use individualized connectivity metrics to be able to figure that out. And this may sound like really, for some listeners, maybe kind of sci-fi, or like really, really out there compared to how you normally think about mental illness. But if you kind of zoom back and you think about medicine, surgeons do this all the time, right? You're not just operating in the heart, you're not just operating in a blood vessel, you're operating in the left anterior descending coronary artery in a particular part of it, right? And it's the same basic idea, is that, you really want to know exactly where. And then what we've developed recently, it was published in the Proceedings of the National Academy of Science last month, was another metric that we've developed where we actually think that we have a good sense of picking who, not just where for everybody, but where for a specific set of people that has a certain biomarker that's relevant for this problem. And so in normal healthy controls, like the vast majority, greater than 97, 98% of people, have a directionality of that dorsolateral, where the information flow appears to flow from the dorsolateral to the cingulate. That makes sense because the dorsolateral functions as kind of the governor of the system. In depression, about 70% of people have the signal flipped, so that cingulate sends information to the dorsolateral and effectively controls it. And so if you think about that, if the sadness region of the brain is controlling the control region of the brain, it's no surprise that depression occurs, right? I mean, in some ways, it's like the prisoner having control of the warden, or however, whatever analogy you want to use, right? But this idea that control is flipped. And what's really interesting about that is that if you place the TMS call and you do in specific our approach into that same connected brain region, what results is a flipping of the signal, and a flipping of the signal is correlated with treatment improvement, right? And to kind of zoom back on the Ibogaine story and this discussion we were having earlier about Ibogaine and what it's doing and what other psychedelics are doing, it's really important to understand that a big piece of it is that, developing a biomarker and trying to validate it, developing a biomarker with psychedelics and trying to validate it with psychedelics, you can do that. And there are people doing that. And I don't have like a kind of a strong philosophical problem with that, but I think from like a acceptance sort of scenario, if you can develop a kind of a modality independent biomarker that works with neuromodulation, but oh, hey, this also works with psychedelics. And hey, maybe it doesn't work in very many cases with SSRIs, given the lower remission rates, then that's very useful, right? Because then, as you know very well, Burton, when you have a test and we know that that test then tells you that the treatment response works, now all of a sudden you don't need seizure count, you can look at the EEG, right? And that's the same sort of thing that we have here, right? Like, you can substitute the phenomenological for the biological. And that's really ultimately what I think psychiatry has to shoot for, and what I would argue the psychedelic community should really be looking for, because if these drugs really do reverse that biology, it's a much stronger argument for widespread implementation, and in some cases replacement of current therapeutics, right? And I think that that's that's kind of a goal of ours, and why we're not really modality specific. Like, we don't, we're pragmatists. Like, it's whatever works and has low side effect burden, not necessarily that it needs to be a given class of treatments.
It's pretty incredible, especially when you invoke something like SSRIs, these medications like Prozac and Zoloft, the conventional current standard of care, which are medicines that treat symptoms. What you're talking about seems to be more of a pathway to getting to the underlying cause of the depression, which can promote more long-lasting, sustainable benefit, which is truly a paradigm shift. I've done some reading, and it looks like there's also a movement comparing what is done in some of the clinical trials with a large flood dose of Ibogaine compared to a microdosing protocol. And I'm curious, as both a clinician and a research scientist, what your thoughts are on these two schools that are looking at larger macro or heroic doses compared to a microdosing protocol. How do we determine which pathway is appropriate, and do you favor one pathway over the other?
Yeah, I mean, whether you're talking about neuromodulation or you're talking about, psychedelics and this whole story of microdosing, which is a tricky one because obviously there haven't been a whole lot of positive signals there. It's this issue of dosing and how to really calibrate dosing, right? Like, if everybody gets the same microdose, not everybody has the same phenomenological effect. I would argue probably not everybody has the same brain effect. How do you then figure out what is a personalized microdose, what is, versus kind of a generic microdose, right? And then kind of relatedly, the field has some information about dosing, right? Like that New England Journal paper from the Compass study had 1, 10, and 25 milligram doses, but that's a one-time dose, right? I mean, we actually have, there's a view that maybe practitioners in certain scenarios, outside of research studies, maybe out of the country or in other scenarios, may have more of a handle on that. But the scientific community and the kind of standard literature that's published doesn't, right? And so this idea that there's a lot of work, even if you're talking about psilocybin or whatnot, there's a lot of work to be done just on dosing, right? And so there's no way, from my perspective, to answer that question in a scientific way. I think that what we're going to have to do is we're going to have to do a lot of the sorts of studies that need to be done to really suss out what an individual's real actual microdose is, and how to dose and how to think about dosing and what chronic dosing looks like, because we're really at this stage talking about single doses, or in the case of MDMA for PTSD, a few doses, 3 doses or whatever. But, we don't have a good sense of it. So we're really in very early days, I would say, from like a published peer-reviewed literature standpoint on understanding dosing for these approaches.
Fair enough. So let's play this out a little bit and say that we are able to run the phase 2 and phase 3 clinical trials that identify
Sure.
psychedelics, whether it's Ibogaine or MDMA, are efficacious therapeutics for putting patients with PTSD or depression into remission, and that's sustainable for a month, 3 months, 6 months. And then ultimately, we can consider if the patient needs to be redosed, even if it's a year out. Some of the pushback that I'm hearing within my circles is that it's going to be very difficult to convince pharmaceutical industries and regulatory bodies to forge forward when you're taking away a daily medication and replacing it with something that only needs to be dosed once or maybe twice a year. How do you envision this being implemented into the Western medical system in a practical sense?
These are the problems. I mean, that's at a fundamental level. That's exactly what the kind of capitalism question ends up being, right? And so, I actually think Ibogaine has an easier road there because it's much more needing of being medicalized from a US regulatory standpoint. There's no world where the FDA goes and says, yeah, we're going to just let you do this in your house or something. And you can just prescribe this and you have a sitter or something. Like, that's not going to happen, right? Like, Ibogaine, because of its cardiac risk, is going to need to follow standard cardiac risk mitigation pathways. I think psilocybin's harder because it doesn't, right? And so in some ways, like, when the level of monitoring aligns with some of the more standard levels of, the drug's need for monitoring aligns with the kind of standard levels of monitoring that happen, that make kind of the setting have the right kind of financial scenario for insurance companies and Medicare and all that. That's a different beast than what psilocybin's got to deal with, where it doesn't have any of those issues as a generality. I mean, there are medical risks with it, that kind of pale in comparison to the Ibogaine risks. And then you're really talking about how do you implement something like that within a context, and we just don't know the answer to that, right? I mean, I know that, I've been hearing whispers that there's a view around trying to figure out who that group of individuals are that are accompanying the individual receiving psilocybin, for instance. Could it be somebody that's a non-licensed individual? Should it be like that? It's all kind of tricky in that domain. I think that part of it may be that where capitalism meets the kind of FDA and kind of the need for monitoring and the kind of like sort of reimbursement issues that you're bringing up is, maybe in a setting where like part of what's being offered is a, let's say, a spa or like whatever, right? Where people can come in, maybe they have a medical monitor, but they also have a setting that has some financial implications. But I think that like the ability to, to kind of roll this out in the standard medical model it's quite difficult, right? It's a really difficult scenario to see work well, and I don't fully understand how that happens. But what I, and there are some, I think there's a category 3 code for psilocybin that came out for like psilocybin assisted psychotherapy, and maybe the ability to wrap the therapy reimbursement into the code is the way to do it, where you have a process for doing that. But it's got to be something like that, right? Where like there has to be a way to not only pay for the drug, but also pay for all this kind of the services. And in this kind of model of psychotherapy, psilocybin assisting psychotherapy, having that psilocybin be able to assist something that also gets reimbursed.
And with that, it brings up another complex and nuanced topic. We have to talk about the potential commercialization and commodification of these drugs with respect to indigenous cultures. And with psilocybin, you mentioned Compass being able to curate a synthetic compound that might circumvent this issue. And MDMA, of course, is synthetic from the jump. But
Yep.
Ibogaine, it being a root bark from a tree that grows in Africa, what sort of measures and respects do clinicians and scientists looking to study these medications ought to take when forging forward, recognizing that this medicine has often been utilized in a cultural context, in a ceremonial context for thousands of years?
Yeah, I mean, it's interesting, right? Like if you look at some of the decrim movements, peyote, mescaline were included in those lists, and then at some point the Native American groups approached the decrim individuals, and then there was kind of a recalculation around the whether or not one should add peyote into that mix because of the limited supply of peyote as a source of mescaline. Now, it is my understanding San Pedro cactus was not included in that, so that's it's not completely eliminating of the peyote story of the mescaline story, but it does send kind of a signal, right? The signal is you can't have it so that the indigenous population loses access to the kind of their substance they've utilized as part of their culture for the price of treating in many cases a culture that then kind of suppressed these same behaviors 100 or 200 or 300 years ago, right? So it's a funny and unfortunate funny, not funny in the kind of ha funny, but funny in the kind of a sad funny that now all of a sudden we're looking at this from a different lens, right? And we have to think in that way. And I think that's the same problem here with iboga and sourcing ibogaine from the iboga tree, right? Is that there is some signal from the Gabonese people that getting a hold of, they've created different legal agreements like the Nagoya Protocol to access Gabonese iboga root bark as a way of studying it, clinically treating people and all that. And the Gabonese, may, stand to get some, money into country for that process. But then, as you look at the price of root bark over the years, the price is going up in Gabon because of this, right? In the population of individuals, the Bwiti that use this as a sacrament end up having to access it at a higher cost. And so the reality of it is that, probably as a generality, if psychedelics are going to happen, maybe the plant was a vehicle for that happening, but the world's going to have to really think about a sustainable way of doing this while paying homage to those cultures that were the ones that held on to it through a lot of, in the case of, the Native Americans and the, Central and South Americans, a lot of, persecution in some cases, right? And not forgetting that, right? That in some ways, we have a big debt that we owe those individuals and those cultures that persevered in the face of persecution by many people that have a similar lineage to myself and probably you, Burton. So I think that's really the issue that we have to face as a society, as Western culture, as we think about this. I think the idea that psychedelics end up becoming part of Western medicine is an important process, because only through, the lens of science can we truly kind of understand it beyond the experiential, which is also important. Obviously, experiential is extremely important, and a part of it that ends up being necessary to understand. But I think there's also a piece of it that ends up being important from a scientific lens, so that the claims that are subjective and experiential end up being validated by other means. Is, unfortunately, science is the kind of currency that the world operates under in 2023.
Yeah, well said. And I've asked this question to other people that I had the pleasure of meeting at the Psychedelic Science Conference in Denver last month, some of whom were practitioners in the cultural context, and they encouraged planting more of this tree and letting it grow wherever it can flourish. My next line of inquiry is one of my favorites that I like to pose to all of the guests here on the Zero Hour podcast. Curious your take. If you feel that it is going to be encouraged or maybe even necessary for psychedelic assisted therapists or the researchers that are treating these patients in the United States in clinical trials and otherwise in therapeutic contexts should experience these psychedelics on their own in order to either enhance or maximize the clinician role to understand how to navigate what might be encountered.
Yeah, there are two perspectives on this. The kind of strict medical model is, as most doctors don't take chemo or Thorazine or whatever it may be, levodopa, whatever, du jour. Certainly your TPA is not indicated in that such, so the idea that the doctor has to experience the drug in order to give the drug from the purely Western medical model isn't there, right? We don't promote that in most cases. We discourage that because obviously the risk benefit is such. MAPS, as I understand it, had a program, right, where therapists would take MDMA as a process of their therapy training. And the idea there, as I understand it, and I wasn't involved in neither the mandate nor the therapy training at that level, was that the individual was able to then access the state in which the soon-to-be participant that they were going to be a therapist for would be in. So the therapist is swimming in the same waters that the patient swims in, right? And if you think about it more from the perspective of, I'm only going to be a good guide if I've gone through the maze myself, and then I can tell you, you have to turn left there, then it makes a lot of sense, right? Because you're ultimately allowing for the individual to understand, hey, like, and this is very helpful, as patient doctor sort of thing, right? Like, this is something that they understand that people will take and that the therapist isn't afraid to take, right? And then with that, they also can give you directions, if you will, and I think in that way it makes a lot of sense, but it does challenge the first model, right? It challenges the kind of pure medical model. We're taking, a well person shouldn't be taking a drug in some sense, right? A well person shouldn't be well in print, in quotations, but a well person shouldn't be, taking a risk benefit scenario in which there's no, in quote unquote, benefit if you're talking about the very narrow lens of benefit being treating full-blown DSM verified PTSD. The counter argument there, which is a counter argument that I've heard a lot and that makes some level of sense, right, is that the world is a traumatic place, right? And that none of us are immune to it. None of us are the boy or girl in the bubble immune to the trauma. But it's one that, again, challenges the medical model. So it's a hard kind of answer to kind of provide without challenge for one of those two parties.
Great. And we've spoke a little bit about mental health pathologies. We talked about traumatic brain injury and your work. I'm curious what other entities within the neurological realm you can foresee psychedelics having a potential benefit in addressing.
Yeah, no, it's a great question. I mean, I think that it really boils down to, at the end of the day, what these things can do and not do. You know what I mean? I think that's we're going to need to do some, mechanistic work and really have a way of conceptualizing it that would make sense to greater neurological community. As you know, Burton, you're a unique neurologist in this case, right? And you're not going to the American Academy of Neurology and giving a plenary talk on psychedelics for A, B, and C quite yet, although that may be in your future. But I think it's one of these things where, at the end of the day, it's probably an even harder crowd to kind of convince, because it's a crowd that has a better handle and doesn't conceive of the mechanisms of neurologic illness as being in the content space. And I can sit here and I can give you a hypothetical thing around why I think glial derived neurotrophic factor and BDNF and affecting tract B and all these things that may have a role in why having a therapeutic effect in TBI. But at the end of the day, we don't really actually know. That's all hand waving, right? Like we haven't done the science at the level to really be able to say this is how this works. We obviously know how levodopa works, for instance, and so we're going to have to do a lot more work, and we're going to have courageous investigators that are willing to kind of go into those spaces and make good arguments to the IRB and to the FDA around why a study of that nature would make sense for a given neurological condition. But if you get past that, then it is that question of what conditions, increasing, maybe having the brain enter into a more juvenile plasticity state would benefit from. And as you can take a 1-year-old who may have a surgery for epilepsy that has the effect of separating, the hemispheres and corpus callosotomy or something like that. And those people end up having retained neurological function because their brain is plastic enough to remap function, right? And so, if it's as such, and we have no idea, but if psychedelics could do something like that, which some people in the basic neuroscience space have proposed, then all of the things that benefit, that kind of we know about a juvenile state having a benefit for reassigning function, right? Which is a lot of things, as and so that's kind of the road, but it's a hard road, and that's a very, I wouldn't go into the American Academy of Neurology right now pitching such a thing until we did more work and really had more data on such an idea. But it is something that I think that is possible, and our TBI work seems to really reflect.
Agreed. And as we come to a near close, I want to give you the opportunity to share any websites or additional work that you're pursuing for people that want to learn more and follow you. Where can they go to find more information?
Yep. So, Stanford Brain Stimulation Lab. If you just type in Google Stanford Brain Stimulation Lab, our lab will come up. we have, a number of neuromod studies. We're hoping to have some movement with the FDA as it relates to, Ibogaine and other things to be able to offer, Ibogaine through a US based study. And, those of you that are interested in such a study, the hope is that within, the next year or two that pops up onto the website as well. And I think keep an eye on things. Our first paper is deep in review, and things are looking very promising, and so that should come out. I'm hoping in the next couple of months.
Well, I want to extend congratulations on that work. I'm confident it's going to be quite an inspiring read. And I also want to thank you very much for your time today and your expertise. It's been an incredible conversation. We value all of your contributions to the space. I also want to thank Psychedelics Anonymous, the Web3 brand that is serving to host and sponsor this platform and podcast. You can check them out at psychedelicsanonymous.com. And finally, turning it back to you for any closing remarks.
Thanks, Burton. I appreciate your work in this area and your courage and in kind of pushing the boundaries. So I really appreciate that as well.
My pleasure. We will be in touch, and you may want to stay tuned because Dr. Nolan Williams and I may be pursuing some collaborative efforts together in the very near future. We will be sure to keep you posted. Thank you so much, and have a great rest of your day.